So today I want to talk about the gender reassignment study. Some say the first gender reassignment study. It was published in 1979, but it evaluates the results of the Johns Hopkins Gender Identity Clinic and Committee that was founded in 1965. I've heard it mentioned in the discussion currently about transgender. Some say it's biased, others say it's important because it's untainted by the discussion today. So I thought it would be interesting just to go through it completely so everybody knows and can make up their own mind. Of course, it is an older document, so the language is a bit different. And also for a science publication, it is old-fashioned in the sense that there's only a few citations, but they're thoroughly mentioned. So the abstract of the paper that summarizes everything we got to go through reads, although medical interest in individuals adopting the dress and lifestyle of the opposite sex goes back to antiquity, surgical intervention is a product of the last 50 years. So since this was published in 1979, they referring to 1930s. In the last 15 years, so since the opening of the Johns Hopkins Clinic, 1965, evaluation procedures and surgical techniques have been worked on. Extended evaluation with 1 to 2 year trial period prior to formal consideration of surgery is accepted practice at reputable centers. And I've highlighted this because from what I've heard, that's not accepted practice today. Cosmetically satisfactory and often functional genitalia can be constructed. Less clear-cut, however, are the characteristics of the applicants for sex reassignment, the natural history of the compulsion towards surgery, and surgery's long-term effects. The characteristics of 50 applicants for sex reassignment, both operated and unoperated, so kind of before and after. The results of long-term follow-up are reported in terms of such indices as jobs, educational, marital, and domicility stability. Outcome data are discussed in terms of adjustment of operated and unoperated patients. Historical, mythological, and cross-cultural acceptance of transsexualism has been reviewed in green. And this is not how any scientific publication would ever start today. Where it's like, if you want to read about this, go somewhere else. Desires to identify with and assume the role of the opposite sex have been recognized since antiquity. Cloudwell introduced the term transsexualism to signify individuals wishing to be the opposite sex, distinguishing them from transvestites. Common usage of the term came about, however, as a consequence of the publication The Transsexual Phenomenon by Benjamin. Abrahams is credited with the first surgical procedure on a transsexual patient. Occasional operative reports followed this initial venture, but the procedure did not become well known until 1953, when Hamburger et al. Reported the case of Christiane Jorgensen. The treatment of Ms. Jorgensen differed from preceding reports that surgery was performed after a period of hormonal castration and psychiatric observation. In 1916, a bilateral reduction mammoplasty in a female wishing to be a male constituted the first procedure at the Johns Hopkins Hospital. And by the way, I didn't mean to color all this yellow, but because it's not a real PDF, it sometimes jumps and I couldn't fix it. So that's where we're at. The establishment of the Johns Hopkins Gender Identity Clinic and Committee in 1965 is detailed by Money and Schwartz. And because Money also is cited later with the publication, I want to go in his Wikipedia page, because what I found out by just looking at his Wikipedia page was quite horrible. And I feel like that's sometimes the thing that when you live in the moment, like they did in the 60s and 70s, they were like, oh yeah, this is great, this is a respected scientist, and only later we have now the hindsight to know what really happened. Mr. Money's Wikipedia page, psychologist, sexologist, and professor at the Johns Hopkins University. And that's how he was referenced in the paper we're reading. And I'm not a fan of physicians, but this is so unethical. So the case of David Reimer. During his professional life, Money was respected as an expert on sexual behavior, especially known for his views that gender was learned rather than innate, so coming from the person. However, it was later revealed that his most famous case of David Reimer, born Bruce Reimer, was fundamentally flawed. In 1966, so exactly at the time where the gender clinic was opened, a botched circumcision left 8-month-old Reimer without a penis. Money persuaded the baby's parent that a sex reassignment surgery would be in Reimer's best interest. At the age of 22 months, Reimer's testicles were surgically removed. He was reassigned to be raised as female and his name changed from Bruce to Brenda. Money further recommended hormone treatment, to which the parent agreed. Money then recommended a surgical procedure to create an artificial vagina, which the parents refused. Money published a number of papers reporting the reassignment as a success, which is just heartbreaking that physicians do such a thing of, becoming famous on someone suffering. Reimer was raised under the optimum gender rearing model. Remember that he considered gender to be learned rather than something you're born with, which is a common model for sex and gender socialization and medicalization for intersex youth. The model was heavily criticized for being sexist and for assigning an arbitrary gender binary. Starting when Reimer and his twin Brian were 6 years old, Money showed the brothers pornography and forced the two to rehearse sexual acts, which is horrible for them being like children, but they're siblings. Money would order David to get down on all fours, and Brian was forced to come up behind him and place his crotch against his buttocks. Money also forced Reimer in another sexual position to have his legs spread with Brian on top. On at least one occasion, Money took photographs of the two children performing these acts. When either child resisted Money would get angry. Both Reimer and Brian recalled that Money was mild-mannered around their parents, but ill-tempered when alone with them. Money also forced the two children to strip for genital inspection. When they resisted inspecting each other's genitals, Money got very aggressive. Reimer said he told me to take my clothes off and I just did not do it. I just stood there and he screamed, "Now!" louder than that. I thought he was going to give me a whooping. So I took my clothes off and stood there shaking. Money's rationale for his treatment of the children was his belief that childhood sexual rehearsal play at thrusting movements and copulation was important for a healthy adult gender identity. Brian spoke about the therapy only in the great emotional turmoil, and David unwilling to speak about the details publicly. At 14 years old and in extreme psychological agony, David was told the truth by his parents. He chose to begin calling himself David, and he underwent surgical procedures to revert the female bodily modifications. Despite the pain and turmoil of the brothers for decades, Money reported Reimer's progress as John Jonah case, describing apparently successful female gender development and using the case to support the feasibility of sex reassignment and surgical reconstruction, even in non-intersex cases. Which essentially means that parents could pick and choose after the fact if they want to have a boy or a girl. By the time this deception was discovered, the idea of a purely socially constructed gender identity and infant intersex medical intervention had become an accepted medical and sociological standard. Reimer's case came to international attention in 1997 when he told his story to Milton Diamond, who persuaded Reimer to allow him to report the outcome in order to dissuade physicians from treating other infants similarly. Contrary to Money's reports when living as Brenda, Reimer did not identify as a girl. He was ostracized and bullied by peers who dubbed him cave woman, and neither frilly dresses nor female hormones made him feel female. In July 2002, Ryan was found dead from an overdose of antidepressants. In May 2004, David committed suicide by shooting himself in the head at the age of 38. According to his mother, he had recently become depressed after losing his job and separating from his wife. So back to the paper. The public controversy surrounding the beginning of the program died away in a surprisingly short time. Initial objection to sex reassignment yielded to an almost routine acceptance, leading Stoller to comment on the neglect of assignment, diagnosis, and treatment selection. Previous reports from the Hopkins series have emphasized the clinical characteristics of applicants for sex assignment and have remarked on their close relationship to the preservation and their inclusion within the borderline personality syndrome. So they're saying here from reports from when they first opened the gender clinic, they said there was controversy. Remember in the 60s, people that cross-dressed were arrested still. But this controversy died quickly. And they also said that, since they were doing it then, they noticed that the applicants often had borderline personality syndromes. The presentation of a biologically normal male or female requesting ablation of sexual and reproductive organs and construction of opposite-sex facsimiles still presents a clinical and scientific problem of no small degree. Familiarity has sometimes obscured the essential problematic characteristics of the request. The attempt in this article is to step back from normalization of sex reassignment procedures in order to look objectively at the long-range effects of surgery. So they're also recognizing that it has been routinely accepted, and they're saying, look, although it is now technically possible to have the surgery, is it really helpful? So they want to take a step back and just get some hard data here. So then they give some literature, and this is what I was saying. It's not actually the first publication, but it is the first publication that really made an effort to be objective and have a before and after scenario. Benjamin reported on 51 reassigned biological males, estimated good results in 33%, and good meaning integration into the world of women, accepted by the families, and reasonable sexual adjustment. Satisfactory 53% and doubtful in 10%. One patient was deemed to have an unsatisfactory result, and one was lost in follow-up. Results were based on personal contact in 46 cases. Randall reported on 29 biological males and 6 females assessed from 3 months to several years post-operatively. 5 men had shown psychopathic and antisocial propensities and 9 depressive illnesses of varying degrees prior to operation. 3 had depressive relapses post-surgically and 2 committed suicide. Comparing preoperative and postoperative adjustment of male patients by means of social and subjective criteria, Randall reported a shift from 86% fair to poor adjustment preoperatively to 72% excellent or good postoperatively. 22 males were satisfied with surgery, 6 were dissatisfied, and 1 wished the reassignment undone. The 6 females received androgens and underwent various surgical procedures, although none underwent hysterectomy and oophorectomy. Results were judged to be excellent in 3, good in 2, and fair in 1. So the problem with this study is then that there were already problems before. These results raise the question if transgender surgery causes depression or enhances conditions that the patients already had prior to the surgery and in addition to being transgender. We're back with the creepy Mr. Money. Money published prefatory remarks on outcome in 17 males and 7 females. All but 1 expressed an unequivocal feeling to having done the right thing by undergoing reassignment. 9 males improved in employment status and 8 remained the status quo. Among females, the figures were 3 and 4 respectively. No females had police records, 6 males had been arrested prior to reassignment, and the 2 with more serious charges were arrested again post-operatively. None became psychotic, 7 males and 3 females married for the first time after reassignment. But here again is the problem that they had already prior arrests. You want the only parameter really to be the wish to be reassigned a different sex and not having all sorts of other problems with aggression or anything else. Edgerton and Meyer reported early psychosocial follow-up in 13 biological males surveyed by questionnaire. All reported no regrets and claimed relief from anxiety associated with illegal pre-surgical cross-dressing. One patient attempted suicide, but none of the others experienced a gross emotional disorder. Sexual adjustment was mixed. 60% reported feelings identified as orgiastic. And here I highlighted the anxiety, but it's not anxiety like we have now. Anxiety, social anxiety, when someone calls you up, you rather have a text. Now, this is specifically anxiety associated with illegal cross-dressing, like actually being afraid of being arrested. Hastings presented data from halfway in a planned 10-year follow-up with 25 reassigned males. No patients with a known history of overt mental illness were accepted into the program, but 2 psychotic episodes were seen post-operatively. 4 patients made serious suicidal attempts and 1 was shot and seriously wounded. Adjustment in this series was rated on a 4-point scale from poor to excellent in each of 4 major categories: economic, social, sexual, and emotional. Criteria for rating poor, fair, good, or excellent were identified in terms of observable or readably inferable variables. So something that you can measure, like this actually happened. This is not just a feeling. I can observe this. I can see it. There's a readout to this. Hastings data indicated post-operative adjustment was average between good and fair. So that would be like a C minus, I guess. The important thing he did was that accepting these people into his program, he made sure that they didn't have a history of overt mental illness, at least. Hoare et al. Reported brief follow-up experiences of 16 reassigned males. 11 were reported to have definitely benefited from the operation, feeling more female and having increased confidence in their new role. 5 were dissatisfied, 3 cited surgical complications, and 2 not feeling fully female. So that was the literature. Follow-up makes it clear that obvious psychiatric disturbances, serious post-surgical ambivalence, and gross dissocial behavior are infrequent complications of surgical intervention. So that is something they already gathered from the data that they had and could review in the 70s. The careful study of Hastings, however, is somewhat more even-handed about post-surgical adjustment than the more dramatic improvement indicated in earlier reports. Hastings was the study that made sure that before the surgery, they had no overt mental illness, and then looked what happened after the surgery. So that really the thing that changed was the surgery and not just mental illnesses that got worse anyway. Then they talk about the Johns Hopkins study. In the introduction, we have read that the first operation they did was in 1960, and then in 1965, they opened the Gender Identity Clinic and Committee. Now in 1971, they want to evaluate how it's going, if it's actually helpful. Now they can do the surgery, but is it helpful? So follow-up was inaugurated of 100 Gender Identity Clinic GIC patients, 34 operated and 66 unoperated. All had applied to the GIC for gender reassignment and had been evaluated prior to the study. The 34 operated patients constitute the total group of patients all known to the Hopkins Clinic who had been operated on at the time follow-up began. 24 were operated at the Johns Hopkins Hospital, 10 at other institutions. The 66 unoperated patients, all of whom had been seen by the first author of this publication, comprised the total active unoperated file at the time of follow-up inauguration. The pivotal points separating baseline from follow-up differed in the operated and unoperated group. In the operated group, it was the point of sex reassignment surgery, And in the unoperated group, it was the initial GIC interview in which the patient was accepted as an applicant and the criteria to qualify for formal consideration of sex reassignment were explained. Living and working in the desired role with concurrent hormones for at least 1 year. So that's what they said in the abstract, that they have this trial period, and that's what they now insisting on, which they didn't insist on with the already operated on patients. At the point of initial GIC interview, the time follow-up began. The unoperated patients had not met the criteria for the trial period and could not be considered for surgery. The situation among the operated subject was more complex. At the beginning of the Hopkins program, a formal, documented, and GIC supervised trial period was not insisted on. So they improved the way they handled the patients. Now they want the sample to be as large as possible so they can see different patterns. They want to include those that have already been operated on, even though the situation there is more complex. Therefore, the surgical qualifying requirements for the earlier operated patients were not as structured as in subsequent years. Among the 34 operated patients, 21 had documented trial periods that would satisfy current standards. The remaining 13 had all been well established in the cross-gender role at surgery, but might not have worked in that role or taken hormones with regularity. Sustained efforts were made to bring the patients to Baltimore for follow-up. Again, to standardize the procedure. All patients included in the follow-up were personally interviewed. Interviews were conducted and utilized only with the informed consent of the patient, ethically. Then the follow-up effort was completed in late 1974. 52 patients had been interviewed. 50 gave consent for publication of their data. In all instances, patients' permission was sought to contact other physicians for confirmation of surgical procedures, medical treatment, and hormone admission. So though they started with 100 patients, they only completed the first follow-up interview and the second follow-up interview with 52, and only 50 gave consent for their data to be published here. Follow-up interviews were organized into 3 components. The first covering the more observable criteria of adaptation, residence, education, and job. The second, family relationships and adaptational patterns of major life intervals, grad school, high school, and the third, fantasy dreams and sexual activity. Interview ranged from 2 to 4 hours in length. Sessions were recorded and transcribed, providing, along with notes, the corpus of research data. Material for this article intended to report the observable and objective factors in adjustment was taken almost exclusively from the first interview component, so the observable criteria of adaptation. It's often called the first transgender study. The inclusion of unoperated subjects is an important departure from the usual procedure of reporting only post-surgical patients. These unoperated individuals were considered a comparison group for the operated subjects. While not a rigorous control group, they provide the only available approximation to it. So ideally you want to have the same person before the surgery and after the surgery. But because they have only a few subjects available, they even included the already operated subjects. From the medical point of view, because of the serious and irreversible nature of the surgery, random assignment to the operative group was not possible. So what that means is that from a scientific point of view, you want to have, say, a group of, like they have here, 100, well, preferably the same gender even, without any other mental health problems, just 100, say, men have nothing else but being transgender. And then they would pick them randomly, have half of them operated and half of them not operated on, and see how well they're doing 5 years down the line. From the patient's perspective, the passionate demand for reassignment did not allow random assignment to the unoperated group. They're being very considerate of transgender people here. This is usually just allowed in life-threatening scenarios. For example, in cancer treatment, you find that sometimes treatment is given without a proper trial because those patients have nothing to lose. Or another scenario would be when the benefits of a new drug are so overwhelming that the physicians give them even without knowing what the long-term consequences may be. I've worked in cystic fibrosis research, and there the new drugs have been given to patients without a proper trial to avoid that patients need a lung transplant. To reiterate, the inclusion of the unoperated subjects in follow-up was considered essential, not only as an approximation of a control group, but also as a group of unoperated subjects who might contribute to an understanding of the natural course of the wish for sex reassignment. Then they jump into their results. First, very descriptive, so if you want to jump ahead to the more interesting bits, feel free to do that. Follow-up was achieved and data could be published for 50% of the sample. Hopeful follow-up percentages in the 70% to 80% range were mitigated against by the realities of the national sample and the difficulty to re-establish contact with some patients. Considering the low follow-up percentage, subjects' representability must be assessed. Table 1 compares sex, race, Holyhead socioeconomic level, age at initial interview, and surgical and consultation viabilities for subjects in those patients lost to follow-up who appeared comparable along these indices. So that's this table 1. Expectations of the comparability included racial distribution and trial period completion in the operated group. The 4 blacks in the operated group lived in close proximity to the interview site, accounting in part for their complete inclusion. Of the operated subjects, 73% had by current standards completed the formal trial period prior to surgery. 2 of the remaining 4 had long established themselves in the cross-gender role, but had not taken hormones regularly. 1 patient had taken hormones regularly, but had not established a full-time cross-sexual identity. The remaining subjects had a still more qualified trial period. Among operated patients lost to follow-up, 59% had completed a formal trial period to surgery. In both operated and unoperated groups, subjects, in comparison to those lost to follow-up, tended more to live in Maryland, the District of Columbia, and surrounding states. Average follow-up for operated subjects were 62 months, and the unoperated subjects 25 months. And this is really the only thing that I find worth mentioning, because for the other things, they took whoever they could, wherever they lived, whatever their ethnicity. But this is really unfortunate that you have this bias of people that had already been operated on were interviewed much later. So more could have changed within the longer period of time. The difference in length of follow-up is a product of having very complete records of the operated cases from earlier years, but having comprehensive records on the unoperated cases dating only from mid-1969. And you see all this data in this table. So the previously operated on are on top, and then the ones that they lost to follow up. The number of patients, sex, race, where they lived, age, socioeconomic level, which I looked up this Holyhead indice, and this would be a high school level. Then if they were operated at Johns Hopkins or in other hospitals, and if they had any complications. Obviously, the unoperated ones didn't have any complications with the surgery, but for those that had surgery, it was about 50%. In the next section, social change, they comment on their results regarding the social standing of the patients before and after the surgery. Frequency of change of residence was selected as one index for social stability. In looking at this variable, the average number of months per given address was compared to equal time periods prior to and during follow-up. Applicants for sex reassignment had been noted to be unsettled, moving frequently and leaving no forwarding address. Behavior attributed to the insecurity of masquerading prior to genital surgery. For both operated and unoperated subjects, however, there was slightly more residential instability following surgery or interview. The average number of months between moves for operated subjects were 20 pre-surgery and 18 after the surgery. For unoperated subjects, 12 pre-contact and 10 follow-up. So they were hoping to see that after the surgery, the people had more stability in their lives. But what I see in those numbers is that those that already had surgery and that were older and didn't have the psychological support of the program and came up in a time where there was less acceptance for transgender people, as they said in the introduction, with this program came an acceptance in society. I want to say they had to be transgender on their own merits, and those people had already more stability in their lives. Job and educational levels they measured with the Hollingshead questionnaire were selected for the two other indices for social adjustment. Job levels indicated a slight upwards trend for both groups, somewhat more for operated subjects, from 4.9 to 5.2. 4 would be a high school degree and 5 would be college or at least 1 year of training. So it's not a whole lot that it improved, and for the unoperated subject it was higher to start with, and then it was a little better for the second interview, but occurring over a longer average follow-up period. Yeah, because the first operated subjects were interviewed after I think 3 years, and the unoperated subjects after 1 to 2 years. Educational levels initially and at follow-up showed essentially no change. Yeah, because that's really not a big change, and it's also not a big difference from operated and unoperated subjects. Operated subjects 5.1 and 5.1 respectively, no change, and unoperated subjects 4.0 to 3.9 respectively. And generally, the operated subjects were less well educated than the unoperated subjects. Socioeconomic levels of individual patients were usually the same as those of the family of origin. Yeah, so whether or not they had a surgery did not really make as much of a difference as their social background. Since job level is an important index, subjects were used as their own control, so not just comparing the two groups, but looking at each individual. Inner frequency distribution of job level changed during follow-up. There was little observable difference between operated and unoperated subjects. 47% of operated subjects and 43% of unoperated subjects showed no change, and 74% of operated and 71% of unoperated subjects were bracketed between a decrease or increase of 1 job level in comparison with baseline. So this goes to show that whatever other benefits the surgery might have, it doesn't mean that all of a sudden these people excel and have insane economic growth. Psychiatric contacts were compared for unoperated and operated subjects. 72% of unoperated subjects had psychiatric contact prior to the initial interview. In the follow-up, only 28 had further contact. This contrasts with the 33% and 8% of operated subjects at comparable times. The bulk of the psychiatric contacts represented forays into search of understanding or certification of sex reassignment. And this is in line with what they said, that now they have more psychiatric contacts for the patients and a trial period for the yet to be operated patients. Whereas in the past, these numbers were much lower, meaning that the patients were on their own before and after the surgery. 2 unoperated patients were psychiatric inpatients prior to being interviewed, and 1 was follow-up continuously in post-hospital care. 1 unoperated subject was hospitalized during follow-up after undergoing sex reassignment elsewhere. 1 operated subject had been psychiatrically hospitalized prior to surgery, and 1 was hospitalized after surgery. Reversal of surgery. One of the serious potential complications of sex reassignment surgery is the possibility that the patient will consider that a mistake has been made, Reports of such cases have been both anecdotal and documented. In the Hopkins series, a biological female who had undergone mastectomy, removal of internal reproductive organs, and phallus construction eventually requested removal of the phallus, but not negation of the entire reassignment procedure. This request came after many surgical complications. She was later hospitalized briefly for painkiller dependency and suicidal ideations. None of the other patients were known to have requested an undoing of the surgical procedure. So nobody had regrets, but this poor woman had so many complications with her surgery that she requested some of them to be undone. So this is interesting. This is the continued pursuit of sex reassignment. Obviously, those that had already been operated on are not included in this. But of the 35 unoperated patients, 14 pursued surgical reassignment essentially to completion during follow-up. 5 underwent their surgery at Hopkins and 9 elsewhere. Another was approved of surgery at Hopkins but did not follow through. At other institutions, 1 patient underwent augmentation and castration, but no genital reassignment, and another underwent rhinoplasty and thyroid cartilage shave. In other words, of the 35 unoperated subjects, 5 completed the trial period satisfactorily, were offered sex reassignment at Hopkins, and underwent surgery. 1 patient completed the trial of living and working in the opposite role and taking hormones for, I think, half a year. He was offered surgery but declined. He's included in the residual unoperated subjects. 9 of the 35 sought surgery elsewhere without satisfactorily completing the trial period. 5 male unoperated subjects had given up anything approaching pursuit of sex reassignment during the follow-up, although they did at times nourish fantasies of being female. The remaining 29 patients still stated an active interest in sex reassignment without either completing the trial period or pushing on to surgery. So I thought this was really interesting that actually only 14% underwent the complete surgery and about 60% actually no longer wanted surgery. And I thought it was interesting that it was really 6 patients that completed this. I don't think this is a high threshold of living and working in the opposite sex and taking hormones for half a year. That's a very reasonable request. And even then, one of those people no longer wanted the surgery. Overall assessment of outcome. The observation that some unoperated patients did subsequently undergo reassignment established 3 groups of interest. The original operated group, an originally unoperated but subsequently operated group, an unoperated but not subsequently operated group, constituting the residual unoperated subjects. Table 2 outlines demographic and surgical data for the 3 groups. Originally unoperated but subsequently operated patients, like operated subjects, are, on the average, slightly older and of lower socioeconomic level than unoperated but subsequently operated subjects. There was no difference in psychiatric contact between the residual unoperated subjects and those who were unoperated originally, but subsequently operated on. So this might be due to the time also, that those that already had been operated must have been operated early 60s, I guess, and then because times change, now there's more psychiatric contact for people wishing to change their gender. The residual unoperated group was followed up for an average of 27 months, whereas the subsequently operated group was followed up for an average of 21 months. And this difference is not very striking for me, the 27 months to 21 months. So now it's really getting interesting, comparing outcome of the 3 subject categories, because the question that they eventually want to answer is the surgery helpful? Up to now, they just kind of described the demographics that they have. The ones that have already been operated on were on average older, and they have kind of completed their trial period of living and working in the opposite sex and taking hormones on their own, having less support from psychiatrists. And the initial unoperated people tend to be younger and tend to not follow through with the surgery. maybe because of the acceptance that this program brought, they now want to know if these people live a better life that had surgery. So they take all the information that they have from the Hollinghead questionnaire and want to summarize it to only have a few numbers we can look at. So they say in order to compare outcome of the 3 subject categories, initial and follow-up adjustment score were calculated by summarizing scores based on concrete behaviors in 4 categories: legal, economic, marriage or cohabitation, and psychiatric. An effort was made to weigh the score so that no one category was overrepresented as a determiner of outcome. Table 3 indicates the scoring system. Most of the scoring is self-evident. However, if the patient is male requesting reassignment as female, the gender-appropriate cohabitation or marriage means that he lives with or marries a man as a female. A non-gender appropriate situation would be one in which the patient, while requesting sex reassignment, nonetheless cohabitates or marries as a man. And by the way, this is how times change. I don't think today you would call it gender inappropriate if 2 men or 2 women would decide to live together. Table 4 lists the mean and standard deviation in each group initially and at follow-up, as well as change scores. The lowest initial mean score was the operated subjects. However, there was no significant difference among initial adjustment levels for the 3 subject groups. So you can say that those that were operated earlier and had to live with more prejudice from society did more poorly, but actually it does make a statistical difference. So as far as the math is concerned, they're kind of doing equally poorly. Adjustment scores at follow-up reflected a positive shift in means. So this is the mean value that is negative in all categories, and they all have positive values here. So regardless of having been operated on earlier or having been operated on during this trial, or not being operated on at all of them have a positive shift. A narrowing of the ranges and a tightening of the standard deviation. The range shows what scores the individuals had. So within the operated group that have a negative score of about 2, some people were actually doing really, really poorly with -18. There was no one in the other categories that did quite as poorly. The operated and unoperated, not subsequently operated subjects showed nearly equal means, both more highly positive than the group operated on during the follow-up. So the values at follow-up for the initial operated group and the subsequently not operated group are somewhat similar. Those that do have a lower value here are the ones that were operated within this program that had the psychiatric support, but there is again no significant difference in the follow-up scores. So even though you can say, well, the operated on during this Hopkins program did less well, they don't do significantly worse than the other groups. On the other hand, change score, so now comparing within the subgroup, for operated patients approached significance, and for unoperated, not subsequently operated, were clearly significant. So they calculated the change from -2 to +1, and then you have the change is +3.13. So this difference can either come from the surgery or passing of time. And then say in the unoperated, subsequently not operated group, that comes from -1 to +1, and this change adds up to +2.4 and is highly significant, mostly because of the range being smaller here. So in that case, since they didn't have surgery, just by the passing of time, they did significantly better. Change score for unoperated subjects subsequently operated on as a whole are not significant. The poorest follow-up score were seen among that subgroup of subsequently operated patients who precipitously pursued surgery elsewhere. So those that didn't stand the 1-year trial period. Those unoperated, subsequently operated patients who underwent surgery at Hopkins had a mean adjustment score of +1. So this is not what they show here in the table. They just say they had more information about this group, and they say that those that were operated at Hopkins had a +1 here. In the original operated group, a comparison of initial and follow-up adjustment score as well as change score was made for those subjects who had completed a formal trial period. And those who were pre-surgically trial was less extensive because they weren't required to do the trial period, but most of them did anyway because that's just how they want to live their life. No statistically significant difference was found. Interpretation is difficult because the small number of patients, but there was a tendency for those subjects without a formal trial period to have lower initial and follow-up adjustment scores than those subjects with more rigorous trial periods. So those people who are very clear on what they want and without being forced by this program to live and work in the desired gender did better before and after the surgery. At the most simple level, these data suggest that significant change in adjustment score may be achieved either through surgery or through the passage of time in association with some contact and acceptance into an organized evaluation program. Operated patients who could not withstand the rigors of a trial period of living and working in the desired gender role clearly did less well than the unoperated subjects or their fellow operated subjects. So they come to the same conclusion as I did. To the last section, the comment from the authors: although only 52% of the samples was interviewed, subjects' initial values seemed compatible to those of patients lost to follow-up along important demographic indices. None of the operated patients voiced regrets at the reassignment. The operative loss of reproductive organs or substitution of opposite sex facsimile, except one previously noted. And that was only because she had so many complications with the surgeries that she had some of them reversed. Socioeconomically, operated and unoperated patients changed little, if at all, with operated patients demonstrating no superiority in job or education. The operated group showed greater residential stability. Unoperated subjects made more use of psychiatric contacts both before and after the initial interview, which relates to their somewhat higher educational level and the recent greater emphasis on psychiatric screening. Additionally, these patients, being unoperated, continued to seek various psychiatric endorsements for their request. 40% of the original unoperated group pursued surgery to the point of gender ablation during follow-up. 14% gave up all active pursuits. It is important to recall in interpreting the data that while both operated and unoperated subjects were followed up for substantial periods, the originally operated group was followed up for an average of 62 months, whereas the originally unoperated group was followed up for an average of 25 months. This difference may influence data interpretation in various ways. For example, it is important to realize that the group of unoperated subjects may continue to characterize itself more definitely as time goes on. It seems likely that the percentage of subjects who are eventually operated on or who drop all pursuits of sex reassignment will change from what is reported here. On the other hand, 5-year follow-up is certainly ample to demonstrate socioeconomic importance and stability. The failure of the operated group to demonstrate clear objective superiority over the unoperated is all the more striking. So they say if they followed the trend of the unoperated group, they assume that they would do even better over time and might exceed the operated subjects even further. The initial adjustment score indicates that the originally operated group was slightly more distressed than the unoperated group. Over follow-up, the original operated group and the residual unoperated group, not subsequently operated on, reached comparable adjustment levels with a degree of positive change approaching significance for operated subjects and being clearly significant for unoperated. Those patients who pursued surgery, particularly those who pursued it precipitously, showed levels of distress close to initial levels. It seems clearly beneficial for patients to be considered for surgery within the environs of an organized program. Abandonment of a program and precipitous request for surgery are contradicting for it. So people that really, really are desperate to get surgery but cannot take part in a program and do a trial period are contradicting themselves. In the Hopkins program, no attempt was made to rehabilitate unoperated patients in the cross-gender role. The patients were seen infrequently, were not given hormones, were not urged or instructed in either direction. The program is interested, concerned, but not interventive, recognizing the strength of the wish for sex reassignment, but adopting a position of watchful waiting with regard to it. For those patients who elected to pursue surgery, however, there came to be an instance on full completion of trial period of living and working in the desired gender role for at least 1 year, with concurrent hormones prior to formal consideration of surgery. Selection for sex reassignment was essentially self-determined by the patients, dependent on their motivation, capacity to organize, and degree of ambivalence. It was not thought because of the serious, irreversible nature of the surgery that patients could be randomly assigned to operative or non-operative categories. Constructions are possible. The most conservative interpretation of the data is that among the applicants for sex reassignment, there are operationally two groups in the phase of a trial period: self-select for or against surgery, and that in either instance, improvement will be demonstrated over time, as judged by observable behavioral variables. Sex reassignment surgery confers no objective advantage in terms of social rehabilitation, although it remains subjectively satisfying to those who have rigorously pursued a trial period and who've undergone it. So there you have it. For their time, 50 people was a decent sample size. Today, so many people get operated on, it would be easy to reproduce this study and confirm or deny their findings, but I haven't heard any clinic doing that. They found that no one really regretted the surgery and made no attempt to hide the fact, which makes me think that Meyer and Reter are not biased and really not against transgender surgery, like some are suggesting today. But they did find that the people that didn't get the surgery also improved in the 4 categories that they looked at. Legal, because they no longer got arrested for cross-dressing. And remember, this is the 1970s, so this might not even apply today at all, depending on the country you live in. Economics, so job and education, marriage or cohabitation, and psychologically, which covers a lot of ground. And 14% of those that initially were set on having surgery no longer wanted any. This is particularly interesting for health insurance, or more important, even for countries that have national health systems, because this surgery doesn't seem to be a cure, so should be covered by insurance. Also, I thought it was interesting that some people struggle with the 1-year trial period. I really assume that someone who is set on having permanent surgery can live in the opposite sex easily. And as it were, it was mostly those whose well-being didn't improve as much by the surgery. It goes to show how important such a trial period is. From what I've heard, it's often no longer required, and it would be laughable if it wasn't so sad that what was considered advancements in mental health in the 1960s is thrown overboard in the 21st century. What I've personally learned from this paper, being a dispassionate scientist, I can say no physician ever did anything for me, but apparently you have to be passionate for physicians to give you treatment, even surgery, and even if they're not actually sure that it helps. It baffled me that they said because of the serious nature of the surgery, they didn't want to deny it. But I would think because it is so serious, you would want to make sure it actually helps. But what do I know? I don't have to deal with passionate patients. But again, you can't say they are transphobic.